enjoyed your entire 5 minute, almost 7 minute break. And so we're going to move into our breakouts, but I want to turn it over to my co-host, Andrea, and let her give you a little bit of guidance.
All right, everybody. So you have 4 breakout groups and then a main room. And so you're going to be randomly assigned to one of those places. And each group is going to engage with 2 different sets of speakers for 30 minutes each. So it's going to be a little bit like speed dating. At the end of the hour, then we're going to come back together and we're going to share some of the richness of the conversations that happen in each of the breakouts. And then Hannah, with that, can you start sending us out to our breakout rooms? Oh, no, I'm going to do this. Mm-hmm. Ready? Okay. Well, welcome everyone to this plenary where we're going to hear 2 presentations. We'll begin with integrating the 4 M's age-friendly health systems framework in CVS Minute Clinics, accessing age-friendly health education tool. The co-presenters are Mary Dolansky, who is Associate Professor at the Francis Payne Bolton School of Nursing at Case Western Reserve University, and Ann Ponard, who is the Lead Director of Clinical Quality at CVS Minute Clinic. Mary and Ann, please turn on your cameras if you haven't already and unmute. You have 25 to 30 minutes and we're looking forward to hearing from you.
Great. I just want to check that you can hear me.
Yes.
This is
Yes.
Ann. Excellent. Good morning, everyone. I'm so glad to join you today. I'm up here in Woonsocket, Rhode Island, and my colleague Mary is in Cleveland, Ohio. We're just returning from the IHI National Forum, where we celebrated with several other groups who are have joined the age-friendly health systems movement. And we're really pleased today to share with you our experience of implementing age-friendly health systems at the Minute Clinic. So we'll share a little bit about our experience and hopefully that'll help you understand our approach to implementation and improvement science in the area of providing excellent care for our older adult patients. So I do want to acknowledge our work with the John A. Hartford Foundation. They are the Age-Friendly Health Systems, as you may know, is an initiative of the John A. Hartford Foundation and the Institute for Healthcare Improvement in partnership with the American Hospital Association and the Catholic Health Association of the United States. Our objectives today are to describe the age-friendly health system movement as funded by John A. Hartford and the Institute and worked on and supported by the IHI, to identify education and implementation strategies to ensure uptake and sustainability of the 4 M's in clinical practice, and to integrate strategies to teach age-friendly health systems interprofessionally. So we'll go through these 3 areas throughout our presentation today: age-friendly health systems, what it is, our strategies, and our implications for interprofessional work. So you may have heard of age-friendly health systems. Terry Fulmer, president of John A. Hartford Foundation, has set a goal of ensuring that older adults receive evidence-based care in every setting for hospital-based primary care, urgent care, convenient care, and ensure that is available to all the older adults as our population is aging. The IHI mission, of course, is to improve health and healthcare worldwide, and their vision is to ensure that everyone has the best healthcare possible. And so in keeping with that, they're very aware that evidence-based care is not reliably applied. And we have a lot of evidence-based geriatric care models that have proven very effective, yet only a very small portion of those are actually reaching those who could benefit. It's very difficult to disseminate and scale activities and evidence-based care models into actual clinic practice. So we know that the 4 M's is a evidence-based framework for age-friendly care. What happened was IHI and John A. Hartford and other groups brought together a panel of geriatric experts in 2017, 2016, 2017, and they identified 90 different geriatric care models based on evidence and 40 years of geriatric practice in this country and worldwide. And they scaled it down to 4 specific framework practices, an essential set of evidence-based practices that any practice could use. And that was really incredibly important that these 4 practices, as this evidence-based practice care, would cause no harm and would also be consistent with what matters to the older adult and their family. Their goal was to reach 2,600 hospitals, practices, convenient care clinics by June 30th, 2023. And they've had a growing number of partners, including the Minute Clinic, but as you can see, many on the screen here. And there's 2 levels of participating in age-friendly recognition. One is the participant level, and 2 is the committed to care excellence level. And IHI is really excellent as they're spreading this work to develop a number of guides that help people understand how to implement, become a participant in age-friendly care, but also how to become committed to care excellence, which is on the next level up, where you're submitting data on how well you're doing with age-friendly care. They also have been conducting action communities that engage people over a 7-month period with experts to support them in implementing the age-friendly health systems framework. So they've actually met the goal of 2,600 and exceeded it, and it's growing. And they have over 2,900 hospitals, practices, and convenient care clinics across the country, and nursing homes as well, that have joined the movement. So as of recently, Q4 2022, here we are, 2,900 practices are considered participants in the age-friendly movement, and 852 have reached the committed to care excellence status. And Minute Clinic is among them. So Minute Clinic, if you're not familiar, is the convenient care clinics that are located in CVS Health pharmacies. We see around 6 million patients a year, although with the COVID pandemic, our population shifted a little bit, but around almost 1 million older adults over 65 each year. We have 1,100 clinics in 36 states in the District of Columbia. It's essentially a walk-in, but also you can schedule visits. We have a number of licensed, board-certified nurse practitioners and PAs who staff the clinics that are accredited by the Joint Commission. And our care is less expensive. We don't have the overhead of urgent care or an emergency room, but we do serve as a safety net for the community, I think. And a lot of older adults come in for a preliminary visit and then are referred because of what we are able to find and identify in the Minute Clinic. We use evidence-based clinical practice guidelines for all of the services that we provide, and we deliver a very high rate of patient satisfaction, and our Net Promoter Score is in the 80s, high 80s, mid 80s. So let's get back to what age-friendly 4Ms care is all about, if you haven't heard of this. Part of being an age-friendly participant or committed to care excellence status organization is defining what the 4Ms mean for your organization. So the first M is what matters most. So knowing and aligning the care of each older adult's specific health outcome goals and care preferences. This means some different things in a hospital versus a convenient care clinic. For our purposes, it was to include in every visit a discussion of what matters to that patient about their health care. Ask them and document what matters to them, and then act on it, meaning align that what matters approach to what matters to the other M's and their treatment plan. From a medication standpoint, age-friendly institutes, if medications are necessary, they use age-friendly medications that don't interfere with the other M's. So from a Minute Clinic standpoint, this was assessing all of their medications against the American Geriatric Society Bears list. We have a way to do that through the EHR that facilitates which meds are on the AGS list so that it can have a discussion with the patient, and to educate, de-prescribe, or refer to the physician who prescribed the medication. Talk about using pill boxes, brochures, other safe measures with pharmaceuticals and medications and supplements, and then document that. Mentation, we had 2 components. One was identifying depression early on and assessing a PHQ-2 and PHQ-9 for every patient 65 and older, acting on that in terms of referral, education, supporting tips on healthy aging and how to communicate any abnormal findings. The second part of mentation for Minute Clinic is dementia. Now, there is a third part, which is delirium. We don't see a lot of delirium at the Minute Clinic in an ambulatory care setting. Occasionally we do when someone's having a UTI, but if need be, we can refer to that. But for dementia, we're looking at assessing a mini cog and getting them the help they need for memory care or a further neurological assessment. And then finally, mobility, ensuring every older adult moves safely every day, assessing using a modified timed up and go, assessing their use of durable medical equipment, educating and using a brochure to share tips on safe mobility. So these are the 4 M's, and they really are meant to be used as a set. So we can certainly see that each one of them has value. We can sometimes get to one or more of them, but the goal is to assess all 4 together. So over 3 years, we've had over 40,000 visits where we've been able to demonstrate use of all 4 M's as a set, and actually over 370 encounters where we've used one or more of the M's in an assessment and action framework. And we've been increasing this over the last 3 years when we started the implementation and have been moving forward with sustainability and other measures to increase the scale of using the 4 M's in practice with our nurse practitioners and our physician assistants. Some of the interventions we've used have included things like PDSA cycles and other interventions where we can actually see in the scale up where we've held a cycle and what the impact has been. Some of the other things we've done besides the PDSA cycle, we've increased the visit time for our older adults from a 20-minute to a 30-minute visit to allow for assessment and use of the 4 M's. We also added the 4 M's as part of our performance review for our NPs and PAs. And you can see this is just an example of one of the PDSA cycles where we were able to shift using the 4 M's significantly before and after the 4 M's pilot. And Mary Delansky is going to go forward and share a little bit more about our education strategies and our implementations for interprofessional work. Thank you. Mary?
Great. Can you hear me all right? Great, thank you. So I just wanted to share that how we implemented this age-friendly care delivery model into the Minute Clinic has some bearings on how to implement geriatrics concepts into interprofessional education in schools and in residency programs. And so I think a change sort of model for this implementation really includes learning healthcare organizations where they're willing to learn and improve, just like educational systems need to be. And then we really need to embrace, even in education, for making change, quality improvement methods, because they're very powerful. And then also methods from implementation science, so that these are the, I would say, the vehicles or the methods that we can use to make these changes to enhance geriatric education in schools and in practice. So we really used a lot of quality improvement methods, and Anne is the director of clinical quality. I'm a faculty member at Case Western Reserve University, and I do use these methods in my education improvements. It really requires an infrastructure to help to align and to base changes on. And in practice, a lot of change can be facilitated by the electronic health record, where we can work more interprofessionally using our EHR documentation platforms. And then I think for all of us as educators and as practitioners in geriatrics, really thinking about reflection and then making change using the Plan, Do, Study, Act philosophy in small test cycles. We did rely a lot on implementation science, and again, reaching out to all of you to look into the science for educational transformation. And then the next slide just demonstrates a little bit more about that. We did publish some of this work. We also published a piece in nursing education on using quality improvement methods for educational transformation. Next slide. And then, of course, in all education, logic models are really important to drive the change. And this is just the example of ours, just as a reference point for this work. This transformation work in enhancing our education in geriatrics does require some planning on evaluation. Okay, so some implementation strategies that I think are important for us to make change include this professional development or education. And then enhancing some practice-based tools. So not relying just on education, but putting in some tools to help our learners to integrate age-friendly into their care in all levels of education. And then definitely we need infrastructure support, again, to drive change. And in infrastructure, what was used at the Minute Clinic really included a lot of data analytics, a lot of managerial support, intranet resources. As we all know, best practice or alerts, enhances performance, and then a dashboard. So we do know that it's very important for healthcare professionals who are trying to integrate geriatrics care into their work, and also students need feedback back to demonstrate how they're doing in order for them to improve. Next slide. So some other vehicles to help us with change, again, is the health record, the EHR, which really templates that are for focused documentation for geriatrics care. So with the 4 M's, this was a key to have a smart set in the Epic where all documentation for these M's occurs. Again, this is important for learners and also for healthcare professionals. And then sort of like simple tools to help to remind people that this is a part of our care delivery. So this was a pocket card that we used to help the patient to know we are delivering age-friendly care at the Minute Clinic. These tools would also be very helpful for the delivery of geriatrics care in all practice settings for our learners too. We also guided a lot of our change transformation with a patient brochure to guide the whole care team on what is age-friendly and how to deliver it. And the next slide demonstrates the 2 sides of this brochure. Again, these are tools to help drive the delivery of the age-friendly integration, not only in practice where we used it in Minute Clinic, but then also in education. Really helps those learners to participate in geriatrics care without really having to think about it. It's an automatic integration. And then here's another toolkit for automatic integration, demonstrating to help the Minute Clinic nurse practitioners, but also to students. Where do you fit geriatrics care in a normal, this would be a primary care visit, but these kind of tools could also be used for learners in inpatient, how do you align age-friendly 4 M's assessments and act-ons in everyday delivery of care to patients in the hospital? Next slide. Another piece learners have a hard time with, our nurse practitioners did, I'm sure other learners, nurses and physicians and physical
Sock shoes on,
therapists.
come on, everybody, get your stuff on.
Oh, somebody needs to mute. Is confident conversation. So our learner or NPs in the Minute Clinic had trouble with how to tell a patient, I'm going to assess your mentation. I'm going to do this mini cog. So we provided these confident conversations. So these would be good tools for students also to help students to have the language ready for how to deal with these kind of tense conversations with older adults with cognition. Next slide. And then we also have a nice website for learners to attend to that we developed, the AFHS resource portal, that has a lot of great educational strategies and resources. And then the next slide demonstrates another tool that learners could use, but that we use for our nurse practitioner and physician associates, was what to do when you have an assessment that is not normal. So we gave them decision trees to help guide their actions then when they did assess some abnormalities with mentation, what matters, mobility, and medications. Next slide. So I think those were some tools that we use that would also help learners to integrate geriatrics care into their practice. But professional development and education is another key. And in our Minute Clinic initiative, these are the things on the left that we implemented. The important thing was an orientation, getting everybody set up to know that age-friendly care should be delivered to every patient who's over 65 every time they have a healthcare visit or any kind of healthcare delivery in any setting. That nurses and also students and residents should always be thinking about this delivery of the 4 M's. Next slide. So we knew that we couldn't teach everybody one-to-one, and so we developed a virtual clinic, which was a way for the students to really learn what the 4 M's were and how this could be integrated into a normal visit. That kind of cues them to, oh, here's an opportunity to assess mentation, or oh, here's an opportunity to connect their medications with maybe their instability with mobility. So this virtual clinic not only teaches the 4 M's to our providers, but then also helps them to know and act on, measures their competence in this area. So this practice in a virtual way, I think, is a way of the future for geriatrics education, to expose our students to other ways of learning about good geriatric care. Next slide. And then an important part for all of us as educators, but we also did at the Minute Clinic, was measure our impact. And so we were always looking at our outcomes and metrics on a dashboard. Again, just a reminder to us in education that we really need to be evaluating and then reporting off how we're doing and giving that information back. So now I just want to talk briefly about some interprofessional opportunities for teaching the 4Ms in education in all disciplines or healthcare professionals. And I think as we've talked about already today, really the shared education. So teaching students early on in early medical school, early nursing school, and sharing this education on the 4Ms and letting them know that this is happening in practice and that they will be expected to deliver 4Ms care to every patient over 65 during their entire education and then beyond their education. So this is a national movement, and students and residents really all need to be on board. Sharing documentation is a key, also highlighting to students that we need to be looking at each other's smart sets in our EHRs and not being siloed in our documentation efforts. Having the students really look at dashboards so that they can see how these 4Ms are being delivered and how we can improve on them. Maybe even having 4Ms huddles. So maybe if we're not doing so good as a team or in clinical with our learners, how can we do better on the delivery of assessment and acting on these 4Ms? And then we can even have our students join some of the Institute for Healthcare Action communities so that the students could see how does change in a very big initiative reach a tipping point so that all older adults are receiving evidence-based care. And then our students could also join in on some journal clubs on ways to better integrate these 4Ms into practice. So the IHI, the Institute for Healthcare Improvement, is also helping us out as educators because there is a module on the IHI website for all healthcare professionals to learn age-friendly care. So this would be a great resource for us all to tap into to prime our students on geriatrics care in a more global sense so that they are ready when they graduate to practice age-friendly care. Next slide. And we at the Case Western Reserve University, we are partnering with the Minute Clinic. Our interprofessional education there at the Minute Clinic, we do have a certificate, which would be another idea for our students, how our students could achieve a certificate in geriatrics care. And just to note that we have taken that model at Case Western Reserve. We have a very large interprofessional education for our nurses, our social workers, our dentists, and our medical students. We have about over 500 learners that meet every Wednesday in small groups. And we do have a certificate program that they can engage in. And part of that certificate program here at Case Western is doing the age-friendly module on the IHI website. And then we also have them meet in small groups, and we have them do our orientation from the Minute Clinic on integrating age-friendly into like a primary care visit. And then we also have them come together and we talk about how interprofessional collaboration can work on the delivery of the 4Ms in delivering assessments of mentation, what matters, mobility and medications, and really looking at them as a set and where those interactions occur and where the different professions maybe have different expertise in those areas and how we then work collaboratively with other disciplines' expertise to deliver excellent, reliable, age-friendly care to all of our older adults. We also have these students, these interprofessional students, play the virtual clinic game, or a virtual clinic on the platform. And because they're so young and technology savvy, they really grasp it and can play this and engage in this virtual environment in ways that are much higher level than our some of our nurse practitioners in practice, and actually a lot of our faculty here at the School of Nursing who are much older. So I do, again, want to just state that I think we need to look at solutions for education and geriatrics to go beyond one-on-one training and in practice training to some of these virtual platforms and simulations to help the students to have other experiences that they might not get in their practice settings that could be more randomly delivered. where the students can kind of consistently get these experiences and we can debrief them in education so that they have a really robust experience with all the continuum of aging, which is healthy aging and preventative care, and really embracing the joy of the delivery of care for older adults, where the stories are rich, the encounters are impactful and meaningful, and that we know that we're taking care of older adults the best we can. So that was all that we had. I think we might have time for a few questions.
I have one. I just wanted to share a story to kind of demonstrate the impact of this educational effort and the implementation and quality, if that's okay. So this is a real patient story that just happened this past week. Ready? The patient, this is from a nurse practitioner who saw a patient, a 75-year-old female, evaluated and treated for a sinus infection. She had a past medical history of neuropathy, hypertension, and Sjogren's disease. She stated that what matters to her was family togetherness and health. She ambulated well and had no difficulty moving around the room. Her timed up and go assessment was normal. She did state she was nervous about going for walks because she lived alone, and we discussed making sure to keep clutter to a minimum and discussing any further safety concerns if need progresses. She had 2 medications that were concerning, Celebrex and Cymbalta. The patient reported that she had discussed both medications previously with her PCP. Her provider reported she could not reduce or eliminate either medication. We also discussed organizing her medications in a pill box, as the patient had multiple medications to keep track of. Her PHQ score was 2 and reported no concerns with mood. However, her mini-cog score was a 4. She couldn't remember the 3 words on 3 tries. I added in a neurologist referral to the record with the patient permission, as the patient reported that memory, especially short-term memory, was a concern. We discussed adding the concern with her PCP as well. Patient had had an established PCP, but it was the weekend, and I also encouraged her to discuss her memory concerns with her family. She was very happy with her care and very appreciative for the extra time and attention we gave during her visit. And all of that sort of perspective of wrapping the visit, which was for a particular illness, but wrapping the visit in age-friendly health systems comes out of having educated, trained, and developed these practice-based tools and all the supports around making it possible for each visit to include age-friendly care. Thank you.
I think while maybe some are gathering or thinking of questions, I do believe the consumers really want age-friendly care. And when we tell them we're giving it, they're like, oh, wow, age-friendly care. This is really good. I'm grateful that you're looking at me holistically and not just treating, the disease or the chief complaint I'm coming in with. So this is also, I think, consumer driven. There's a question from Marianne.
Yes, it's thank you for taking my question. It's a comment I want to make as a geriatric dentist. Is patient focused and based on what matters most. I've been working with the system, age-friendly health system, for the past 4 or 5 years now, which has been a wonderful thing to bring it into the oral health. And I'm finding out, especially in patients with dementia and patients with a lot of advanced physical limitations, it makes more of a redirecting the 4Ms into the evidence care than evidence base. If I want to give you one example, which is often happens, is using SDF, which is a certain fluoride that stops the decay from progressing. And the way evidence-based talks about how to use this, and the way that clinically it's impossible to use it that way, and I just use it the way I think it may work, it actually has worked. And I think if we be able to bring in as an umbrella under where the 4Ms stands, adding the evidence base and evidence care can bring the whole thing more into the person focus that we've been working towards. So I just thought I would make that comment because it was just an experience I've had for the past few years. Thank you for the opportunity.
Sure.
Any other questions? If you just want to open your mic or.
Is the age-friendly health systems familiar to most people on the call?
See some head nodding. Yeah, and I would like to say that I know the last session, the speaker talked a little bit about that, about quality and that it's hard for geriatrics to fit into the quality model. But I do believe, though, that in quality, the Institute of Medicine did state that quality, has those 6 dimensions, and one is patient-centered. And I think that this is really about patient-centered care, really asking people what matters and then connecting all of it to that as a set. And that's what really drives our meaningful care for our older adults and quality care for our older adults. And we do know that the triple aim does include, patient-centered care. So it really is quality. And to align with quality departments for these initiatives, these academic practice partnerships is really key. But thank you all for your time.
There's a question in the chat about any more webinars on that topic. I don't know if that's something the group can share. We have presented a number of times. We just presented at IHI this past week, or yesterday, 2 days ago, and we have another presentation coming up on the IHI Scientific Symposium. And I'll be presenting at the American Academy of Nurse Practitioners next year. So it's getting around, and there are others presenting as well. And then there's a question about the access to the virtual training. Mary, do you want to take that one?
Sure. If you want to email me, my email is mary.dolansky@case.edu, and I'd be really happy to extend that out and see how the prototyping works or piloting works at your institution. The VA is also instituting a national implementation for the 4Ms care, and the GRECs are actually doing sessions of education on it. So if you would like some connections to other presentations, we can connect you to some of those.
We're also making the virtual clinic accessible through the IHI Open School. So if you're an IHI Open, if you have access to that, you'll be able to take some of the orientation and use the virtual clinic through that. Correct, Mary?
Yes, that's correct. It'll be a little while, but it will be there. And that would be great because then students could really practice age-friendly care in different practice settings. Yeah, if you put your email in, I can follow up. Thank you so much.
Thank you, Mary and Ann, for this fantastic session. I think great examples of sort of health systems that are really iterating and piloting, not just piloting, but actually implementing and doing advanced care and moving the needle, I think, in the space. So thank you for that. We're going to hear about transforming attitudes about memory loss from 2 presenters at the University of Minnesota. Teresa McCarthy is a geriatrician and associate professor of medicine in the Department of Family Medicine at the University of Minnesota. And Teresa Schricker is the program manager of the Minnesota North Star Geriatric Workforce Enhancement Program at the university. So Teresa and Terry, please turn on your camera.
Well, thank you. Are you able to hear me all right?
Yes, we are.
Well, thank you for that introduction, and thank you for the invitation to participate today. This is all really great content. Next slide, please. First of all, no conflicts of interest. And next, we just want to acknowledge that our university is located on ancestral lands of Indigenous people. Next slide. Our objectives today are pretty straightforward. We're gonna learn about a simple, effective intervention to increase awareness of the effects of dementia on patients, consider how these activities could impact the future workforce in the context of the rest of the discussion today, and understand or think about how you yourselves might use this dementia-friendly information session in your work, education or otherwise. Next slide, please. The instigating issue for this, and I won't belabor this, is that I'm a clinical educator. I have been teaching geriatrics for many years to all sorts of interprofessional, uniprofessional students, and more recently primary care residents, primarily family medicine and internal medicine residents. And thankfully, as these rotations have become more and more required, not all, I agree with the previous comments, but we're often getting trainees and students who really have had no exposure whatsoever to older people or geriatrics or dementia. And some come and they're ready to fly. They've had grandparents, but many come and just really quite don't understand why they're here and why they have to participate in the kind of activities that I'm asking them to participate in. And as I've thought about this and heard their kind of stereotypical understanding of aging and dementia, I've found that there's a lack of empathy and seems to be a lot of misconceptions about aging and older adults. So I've spent a lot of time looking for a module or some kind of activity, some kind of course that could mitigate this ageism and improve a sense of empathy for the population that they're about to embark care for. I looked a long time, and then next slide, please. I encountered the Dementia Friends program, and if the Zoom gods are with us, this is about a 90-second video, please.
Oh, my package is in front of my door right now.
If you saw someone living with dementia, would you recognize the signs? Would you be uncomfortable? Would you avoid them? Would you be frustrated? Would you do nothing? Or would you be a friend? Would you engage them and empower them to get through their day? Would you welcome the opportunity to help them feel like a part of your community? Would you take even the smallest step to make their world less frightening or confusing? Every single one of us has a unique part to play in the lives of people living with dementia in our community. Become a dementia friend today and build communities where all people can live, age, and thrive.
Hey, Mr. Fredrickson, it's Tuesday. Aren't you going to the store?
Yeah.
Come on, I'll walk with you.
Find out more at dementiafriendsusa.org.
Next slide, please. So that was it, right? That touched the nerve, and at exploring this, I found that the Dementia Friends was really part of an evolving, not just national but international, worldwide movement to develop age-friendly and dementia-friendly communities, and as we've heard about just a little bit in the last session. But the core component of the Dementia Friends movement are these information sessions. Next slide, please. With a really simple goal to, as they say, improve how people think, act, and talk about dementia. It's a community-based model. They're volunteer facilitators that provide group information sessions across communities, which was the original model. It's a train-the-trainer champion type model. So people who attend a Dementia Friends session can do another hour of training and become a champion, and then take the sessions out into their own communities and deliver the content. It's not an education session. We had to take the education word out of our verbiage. It's an information session because it's provided by community members to community members. It doesn't require an academician or a PhD to deliver the content. Oh, we need a mute. Thank you. The content it's a 60-minute program, and it's very highly scripted. It comes packaged, ready to go. It is licensed content, originally developed in the UK, but there are now US licensees. So it is proprietary, but the content is free. It can be delivered in person and thankfully virtually, as we found, and any number of participants can be included. And I just saw this as a really kind of straightforward opportunity with very little effort to engage students in a positive exposure to issues of aging and cognitive impairment. And I really thought it had interprofessional potential as well. Next slide, please. So the content of the session revolves around 5 key messages. Dementia is not a normal part of aging. It's caused by diseases of the brain. It's not just about having memory problems. It's possible to have a good quality of life with dementia. And most importantly, there's more to the person than the dementia. Next slide, please. The content is delivered. It's a very upbeat, kind of low-key, comfortable process. There's didactic presentation a bit. There's some individual brief activities, some reflections about people's perspective on aging and dementia, which I think is helpful for people who've never done that before. There's some small group interactions. There's storytelling. So the champions, the presenters that do this a lot, can augment the content with their own life experiences, their own lived experiences, which really enhances the experience. And then at the end, there's some very practical recommendations for effective communication with people with Alzheimer's disease, and the residents in particular really like this content. I think they find it very helpful. So the content is proprietary, next slide, but I've been given permission to share a little bit of my favorite pieces. And this in particular, the bookcase story, I find amazing. So this is basically an analogy of the brain of an Alzheimer's patient as a shaken bookcase. So as we know, when you shake a bookcase, what usually falls out, the books that fall out are on the top of the bookcase, right? And that is analogous to the Alzheimer's brain, the outside of the brain, the cortex, where complex thinking, insights, and facts tend to be lost from the top shelves. However, like the bookcase at the bottom, even though it's shaken, the books tend to stay on the bottom shelves, which is kind of analogous to the inner part of the Alzheimer's brain, the amygdala, where the emotions and the feelings and the sense of self reside. So even though you've lost some of that complex thinking ability, those emotive and feelings, sense of self remain. And it's a great visual, it's easy to hold on to, and it really kind of provides some context for how to interact with these folks if you don't know a lot about the disease itself. Next slide, please. We're going to skip this video. There is a team activity, actually a competitive team activity to enumerate as many individual steps as possible to accomplish a very simple task, like an ADL. So if you have enough people, you can break them down into teams, and it's quite interactive and fun. And then at the end, next slide, please, there's a very robust discussion about effective communication techniques for persons with Alzheimer's disease. And I won't go through those, but I kind of always thought I was teaching this, and realized as I've gone through these sessions with folks that perhaps I'm not doing as good a job as I thought I had been doing. A lot of insights come out of these discussions. Then to wrap up my comments, next slide. Obviously, we wanted to understand what impact these sessions were having on our health profession students and their perspectives on persons with dementia. So we implemented a study. I want to note that the first 2 authors, Michelle Burning and Amy Parkinson, were second-year medical students when we started the Dementia Friends program. They were some of the first students who received the information sessions, and we're very impressed by it. Obviously, they actually developed this study and did most of the implementation. Unfortunately, I think they're both at residency interviews today and weren't able to join us. Next slide, please. We looked at about 100, our first 100 students, and I'm sorry, I don't have access to the pointer here, but third from the bottom of the program, About 50% of them were medical school students, about 30% were physical therapy students, and the rest were pharmacy. And on the last line, in terms of learning modality, we were able to administer in-person sessions to the 15 people, and then COVID hit, and the rest, the balance, were done virtually, but actually worked quite well. Next slide, please. We utilized a validated scale called the Dementia Attitudes Scale, which incorporates both knowledge about dementing diseases, as well as a measure that looks at kind of the comfort of interacting with a person who's cognitively impaired. It's a 20-question scale. We implemented it just before we introduced the session, and then at the end of the session. And what we found, next slide, please, was that there was an impact on the score. We did improve attitudes statistically significantly between the pre and post session. Next slide, please. And that there was a modest correlation between the baseline score on the x-axis and the impact, the change in the score on the y-axis. Next slide. So our takeaway from this is that with a modest effort information session that's really easily replicated and comes out of the box, can be delivered by students and lay people, does not require an academic geriatrician even to be present, we were able to increase knowledge and improve attitudes of health professional students toward those living with dementia. It's been a very, very positive experience for everyone involved. And I will pass it on now to my colleague, Teresa Schicker. Thank you.
Thanks, Dr. McCarthy. So I'm going to talk a little bit about implementation and just let you know that I'm sharing this information because we really believe it's powerful and that you could do it locally, either with your academic institution or in a clinical setting, or in community settings. So at the University of Minnesota, since we've started doing this, we've been able to train or give information sessions to 825 students and 989 overall, so students, professionals, and community members. And I want to talk a little bit about that first number, 164 health professionals and community members who've been offered Dementia Friends. Many of those are from an interprofessional class, which is taught at the University of Minnesota. It's called the Community Teachers class, and many of those are they're teams of interprofessional students intentionally paired with a community teacher who's a person, typically an older person with several chronic illnesses. And so many of the students and community members who received Dementia Friends actually received it together in these courses, which was a really rich experience for them to have discussion. And in addition, we've also offered Dementia Friends in long-term care settings, so not necessarily related to education, but in long-term care settings with staff, residents, and family members. And as Dr. McCarthy mentioned, this being a train-the-trainer model with champions, some of the people who've been most committed to Dementia Friends have been our health science students. So as she mentioned, there's these 2 medical students who've really taken it and run with it. There's a pharmacy student who's become this outstanding champion who has expanded this in the School of Pharmacy to extend the information sessions to many more students in pharmacy, and then getting more champions from her colleagues. So it's been a wonderful experience for leadership development for these folks in health professionals studies. In the next few months, we're going to be offering Dementia Friends in primary care clinics for medical residents and staff in many disciplines. So a lot of medical resident programs are going to be getting Dementia Friends soon. And then in the coming years, in 23 and 24, we're extending this to all of the mHealth Fairview primary care clinics around Minnesota. So there'll be 56 clinics that are going to be receiving Dementia Friends to their staff. And that'll be intentionally interprofessional as well. Dementia Friends, though, doesn't just have to be offered in those formal settings. It can be offered in faith communities, student clubs, libraries, community centers, and of course, classrooms too. But all of those are options. You can do it online, you can do it in person. We've been able to offer it uniprofessionally and interprofessionally. So student groups that we served, yeah, thank you for moving to that, how it can be replicable. Student groups we've served have been in education and human development, medicine, mortuary science, which has been an interesting recent addition, nursing, pharmacy, PT, and public health. And we really do believe that this is something that you could do in your own community. Again, because it is proprietary, you'd need to arrange for some sort of agreement, a license with Dementia Friends USA or through a state or local organization who has a relationship with Dementia Friends in the UK. If you're going to be using the Dementia Attitude Scale, which many of us would want to do to measure, of course, we'd suggest IRB approval for that. We encourage you to make the lessons interprofessional. If you are doing Dementia Friends information sessions, you can coordinate that with your university center for IPE. And but you could also do it uniprofessionally. So we've done this to a lot of classes. Many of the instructors in our health science programs have opted to just offer it every single year for certain courses. We come in and do Dementia Friends for them for a certain course every year. And so we have a reliable, organized way to make sure that we get this out. And we really invite you to collaborate with us, especially if you want to do Dementia Attitude Scale. We'd be happy to partner with you. So my email address is there. We collaborate locally with our Center for Interprofessional Health at the University of Minnesota, but we're happy to work with you to do more. If you can move to the next slide, I just want to talk about an opportunity for all of you. We are going to be offering a free Dementia Friends information session in partnership with our close partners with the National Center for Interprofessional Practice and Education. If you want, you can register with this code here, and it's going to be on February 15th. You're welcome to be exposed to Dementia Friends yourself, invite students, invite colleagues, extend this to clinical groups, or maybe just IPE leaders in your region. We're very happy to be able to partner with the National Center for this. And to the next slide, if I may, I want to just mention a little bit more about this in context of the Geriatrics Workforce Enhancement Program. So that is our website for our local Minnesota North Star Geriatrics Workforce Enhancement Program. We've created some beautiful resources and a website, much of it in collaboration with the National Center for Interprofessional Practice and Education as well. So there's our website if you want to learn a little bit more, and you can certainly search for information about Dementia Friends and our program on there. To the next slide, please. And then the next, sorry. So a couple acknowledgements that are really important for us. One is an acknowledgement of our amazing master trainer in Dementia Friends, Colleen Fritsch. We added her image here, and she's highlighted on a video, which is in the slides. When you all get the slides, you may be able to take a look at that, but she's just an incredible local champion who makes this happen. And I think you all know how volunteer programs can either be fed with passion or sometimes dropped, but she's just an amazing person who often does many of our Dementia Friends sessions with one student champion, so paired, and people really seem to appreciate the energy that comes from that. In addition, we're always grateful to our metro area agency on aging, which is called Trellis. Next slide, please. And in general, the support for the Geriatrics Workforce Enhancement Program of course, comes from HRSA. Like CVS Minute Clinics, with our GWEP, we also participate in the Age-Friendly Health Systems, which is, of course, through the Hartford Foundation and the Institute for Healthcare Improvement. Our GWEP aims to train thousands of leaders in IP geriatrics team care, transform community primary care clinics into age-friendly sites, and promote dementia-friendly systems and communities to thousands of older adults, families, caregivers, health professional learners, and clinics. So we are continuing to expand, and Dementia Friends is part of that. We're really grateful for Dr. McCarthy's leadership in that. The next slide is simply my email address again, if you want to reach out for collaboration. And we're happy to receive questions that you might have about Dementia Friends content, empathy building, or collaboration on this.
Really excellent.
Sorry about that. Really excellent presentation. Can really appreciate the importance of this. And I wondered if there was anything on the Dementia Friends curriculum or attention to sort of unappreciated mild cognitive impairment. So, you know, we've found in the Minute Clinic, many people have abnormal mini cogs and they seem to be functioning pretty well. But this underlying issue, if you could comment on that. And then can you also put up your context slide again?
Yeah, so such a great question. And Dementia Friends, the information sessions really focuses, I would say, on patients who have moved past the MCI stage and are showing definite signs, recognizable signs of memory loss. Part of the didactic component of the information is a little bit of review about the types of dementia, and MCI is mentioned, but it's not a focus of the exercise. Great idea, though. We can think about. There's all sorts of potential, you know, for educational structures just like this. You know, it lends itself to a lot of additional content, which we'll think about. And you know, what I'll also say is it is just fun. You know how education can sometimes be a bit tortuous and you're, you know, kind of trying to dump information into students' heads and get it to stick. This is just organic. It is just, I really think of it as primarily an empathy building experience. And the education comes along with it and just sticks organically. It is not difficult. It's actually quite a pleasant experience for everybody involved, even those who are, you know, I'm not going to take care of old people. Why do I have to sit through this? It very effective.
A lot of the comments we receive, as Dr. McCarthy mentioned, people mention their grandparents or their neighbors or others who they've been exposed to. You know, some people, of course, have done a stint as a CNA or something, but many people mention their grandparents. So it really hits, yeah, it's an empathy builder, I think. And the way that we describe this when we're offering it to med students or advanced practice nursing students is that that this is, you know, more basic information, but that it's something that they could recommend to their patients and the caregivers of their patients as well. Maybe Dr. McCarthy, you want to speak more to that. You have some more clear language about that, but what do you say?
No, I think you did a really nice job. We initially got some pushback from some of the higher level trainee programs as to, boy, this is really basic content. You know, this really doesn't dig deep into the pathophysiology in the treatment of Alzheimer's disease. And I pushed back and continue to push back pretty hard because I understand intellectually why that they have that initial perception when they hear about it, but pretty much everybody that sits down and participates gets it. It's the gut impact, again, that augments the underlying content and the ability to just take away that understanding of the implications of dementia and what it's like to live with these deficits and how easy it is as a clinician or a community member to improve the quality of life of cognitively impaired people with some understanding and insight.
Well, kudos to your leadership in advocating for that component, because I think we do know in implementation science that what drives behavior change is value. And so what you're driving is, the spark to the change. So thank you for all your work. This was really great.
Thank you. Thank you for the validation.
Thank you, Teresa and Terry. This was a really fantastic session, very accessible, very doable, and I think a lot of some concrete take homes. I think many of those attending will look at. So thank you for sharing your experience, your wisdom, your enthusiasm. It's contagious. I feel excited about it too. Already thinking about where I could take this and have kind of replicate some of what you've done. So thank you for sharing that. I think we are going to be, we're going to be joined here in the, I think the breakout groups will be concluding soon and will be joining us here. So in a minute, when everybody reconvenes in this larger room, we'll do a debrief from the breakout and then we will conclude the session. I think we'll just give it a minute for the breakout group participants to join us.
So I'm having difficulty hearing. Is it just me?
Oh. Let me try. Can you hear me better now? Okay. I will try to speak a little louder. We're in the in-person room here. It's the same.
They having trouble hearing?
It's
just because there is a very soft voice.
Oh.
The gray thing in the center of the room, that's the mic. So just project towards that.
Okay. Well, maybe I'll look up as much as I can. Can you hear me better if I speak at this tone? Yeah, hearing some lots. All right. That's good to know. And I think we will soon be joined by the folks in the back.
Yeah. It's really good. Would that be similar last year?
I can we try that? Yeah, we'll do that.
People can hear you better.
That's right next to it, yeah. It's good idea. Okay, maybe the audio might be better now. I'm sitting in front of a mic. Yes, thumbs up. Awesome. Okay, so we'll continue to give it just a minute as people are joining us back in the large room here, or the large virtual room.
Recording in progress.
I think we'll get started with this debrief and concluding this fantastic session. So I would love to hear a bit from the different breakout groups. So we had 4 breakout groups and we had some folks who were here in the large room. Those who were in the room where we were listening to the integrating the 4 M's and the age-friendly health system. This is an opportunity for those who participated in that section to share aha moments, key takeaways, or even suggestions. I think since there's a lot of us here, it would be best to use the raise hands function, and then we can call on you to share your comments and thoughts. So anybody in the room that was hearing the age-friendly health education tool? Anybody who wants to share any thoughts, comments? Yes, go ahead.
I think the data on the 4 M's and also looking at how we're better defining and helping people with dementia. All of these are great tools, and I think through these forums, we're able to disseminate that information, statewide, countrywide, even internationally. So, because I think sometimes we all want to reinvent the wheel, and somebody's gone before us, and if we could help augment or add on to what somebody's already started, I think it would save us a lot of time. And then really trying to standardize this then across the country, because right now I think the hard part for students is that there's so many different tools out there. They don't know which ones to use, which ones are evidence-based, And so I think if there's a way to keep building upon some of the things that we're finding out there that are useful, then I think it can provide more evidence and more research, more data.
Yeah, that's a great, I mean, that's great feedback for this, for the forum, for this workshop, but then also probably a charge to the team, to the broader group here as health professions educators. How, where, and when do we kind of start to curate this information so that it's accessible to educators on the ground? Yeah.
So one of the take-home messages that I heard from the presentations was making it fun for the students. And I think that something we've been talking about this workshop and actually the previous pre-workshop was that a lot of learners don't want to go into working in geriatrics because they see it as scary or uninteresting or boring, or they're not attracted to it. And I'm intrigued by the idea of making the education fun. And I'd love to hear from you. I know it's changed some attitudes, but has it brought more learners into the classes? We heard I think in one of the breakout sessions, and they may want to comment, that learners aren't signing up for the classes. They offered a class and nobody signed up. So then they stopped offering the class because nobody signed up for it. Does that bring more learners in because you make it a fun, friendly environment to learn about geriatrics?
Seeing head nods.
Let Teresa add her comments. She's had more experience probably on the ground with talking to potential participants, but I do sense that as the students participate, so as the medical students participate, and then talk to the other medical students, and the pharmacy students participate and talk to the other pharmacy students, that there does seem to be a growing interest, or let's say a diminished lack of resistance to participating in some of these offerings. And as we move out into the interprofessional groups and training opportunities, I'm hoping that we do see that kind of organic growth. I think that's likely to be an effective way of moving this forward. Thank you for your insights.
Yeah, thanks, Dr. McCarthy. I agree with that. And I'd also say that part of the strength of our model with our Dementia Friends programming is that it can be peer led. It's a train the trainer model. And so there's some leadership development there and opportunity for the students to take some ownership and spread the word about this really interactive, wonderful content for Dementia Friends. So that's part of the attraction, I think, for some of the students. And for others, it's just that it's approachable content. It strikes a chord. There's empathy building there. It's fun. So we're hopeful, and our outcomes, the data from our outcomes show that yes, they are more excited about the idea of working with older adults or people with memory loss because of it.
Great, we have two hands up, Mary and Martin, and then we'll go to another breakout brief.
Thank you. I just wanted to share that I do think, though, that we need to transform the way we educate and to bring on more virtual learning for these students who are technology savvy, who love the kind of fast-paced action. And the age-friendly health systems virtual clinic kind of delivers on that. So it'll be interesting to see as we develop that and test that, if that might be a way to excite more students and residents in geriatrics care. Because I think that moving our sort of pedagogies for education to virtual simulation, gaming platforms would maybe be exciting. Let's try it.
Yeah, very true. Martin.
I was just thinking about, used to teach marketing, and one of the issues is how you describe something, and maybe by labeling as geriatric, we're missing the opportunity. Like younger students would be interested in lifetime health, and just the words. And I mean, Celine Dion just got diagnosed with a major neurological problem. She's working age. She's going to have a lot of issues that an elderly person would have. So I think if we thought about framing this for our students in a way that is more generic and not as focused and siloed as just elderly, we might get more uptake and interest in it. I mean, the skills, we have a lot of middle-aged Americans who are have developed health problems for many reasons we could discuss for hours, but are basically functionally like a 60 or 70-year-old in their mobility and their health status. And so I would say that there's a skill set here which is about more, not so much about age, but about the functional status of the person. And if we packaged our courses to think about it as skills for dealing with the person, whatever their age, we might get past some of this bias. I mean, certainly in medical school, there's so much interest in, procedure skills and technical skills because of the way the reimbursement is. But if we move past things to have people think about the context in which they're providing care, I think we could maybe get somewhere.
Yeah, I think that also sort of links back to the intrinsic capacity framework, which was functionally oriented, not age oriented. So that sort of connects there. And I think one of the principles we're talking about here, which is sort of learner-centered education, sort of building off of what they're interested in, maybe dovetails us nice into the next breakout group we could hear back from, which is learner perspectives. I see Annette too. So maybe Annette, you can comment, and then it would be great to hear from anybody who was in the learner perspectives breakout.
I just want to respond to him. Number one, just as we have pediatrics, which is developmental growth forward, there is developmental differences physiologically and mentally and sociologically within the elderly. So I disagree with his thing. One of the comments I made earlier was that the reason it has lack of importance within curricula is because of board certifications or licensures, which have deemed that entitlement low risk rather than high risk. And until the boards that make the exams up determine that this is a value and important factor, then the curricula will not reflect that high risk in the same way that pediatrics does say. The other thing that I had mentioned during the education is the addition of non-traditional disciplines such as law, which I think could add much to geriatric law, family care, so many domains of care, especially because many of our families now are non-nuclear, which cause complexity to who makes decisions when the individual is unable to make them themselves. So thank you.
Thanks, Annette. Thanks, Annette. I think you bring some important points. I think it may be ripe for a study to look at the factors that influence learner engagement and interest in advancing in this space. So with that, anybody from the breakout group that was in the learner's perspective session want to share any highlights, aha moments?
Hi. I was the moderator for this group for the learner's perspective, and we did have a few things that came out of the discussion. Mainly was just imparting to the people who are our curriculum builders that this is a population that is not going to go away. It's not going to lessen. It is not going to become any easier to provide services for. And the sooner that we make the changes to embed gerontology and geriatric care into curriculum, we will begin to make changes. But until we actually do that, that to make that step and to make that change in our thinking, that this, to our students especially, that this is the population you will see most likely the most, unless you are going into a field that is completely just somehow siloed away from dealing with older adults, which is very unlikely. Even if you're dealing with just the parents or the family members, you're going to deal with older adults. But providing care for older adults, if you're family nurse practitioner, if you're family medicine, if you're thinking that your primary care, acute care, everything is going to see older adults. So we might as well go ahead and embed this into our training from the beginning and not make it an option, and not make it something that we can maybe learn a little bit more about, but it is the focus because it's our largest group in the United States. As well as the other thing is that we all noticed, especially as we were preparing for this breakout session and the weeks before and the days beforehand, we noticed that we all had personal experiences that led us to gerontology. And so we've talked about this several times today, not just in our learners breakout session, but truly imparting that mentorship, learning experience, almost narrative medicine, where the students are sitting at the feet of patients who have lessons to impart to us, spending time in training. If we only are given 15 minutes to see patients, and in some cases that's generous in some areas, if we can take the time while we're training as early as possible to listen to their stories, to learn and to see their perspectives, the more likely we will be seeing people who are not making generalized thoughts about what gerontology is like, what geriatric care is, and people who will actually go into this field. And just from our own personal experiences, each of the speakers, including myself. So I do believe that those were the main thoughts that came out, but if anybody else wants to chime in, please do.
Yeah, we have Katie who's got her hand up.
Hi, and just a quick thank you to the learners for bringing your perspective into this space. When I was in that group, we also talked about messaging, and I just saw a comment in the chat that I think echoed that as well. We were talking about it in the context of trying to, bring learners into this space, and even more specifically with like food and nutrition and being positive about those messages. And, if you eat, then this is something that is relevant to you, because at some point this will be relevant to all of our learners who are going on to be professionals and potentially in this population as well. So thank you.
Thanks, Katie. Anybody else from that breakout group? It strikes me that if and I'm supportive, I think this is it is important to think about that we need to incorporate this in part of all of our curricula. It needs to be sort of foundational knowledge for health professionals in general. We'd like to teach to the test. I wonder if we need to put some effort behind some concrete, crisp competencies that we can then assess and ensure kind of are delivered by our training programs.
That was also a comment that came out of our session, was the importance of changing the boards to include aspects of gerontology. That was a great comment that came out as well.
Yeah, Jenny.
Yeah, and I have college age kids and who are not in healthcare, but I really have encouraged them to take classes in gerontology. I am just convinced that no matter what your profession is in life, you have to know about older adults. And something that I share with my own students is that there are so many brilliant entrepreneurs who have made all this amazing technology for older adults, but it's not usable because it's not older adult friendly. So I really think it's something that all of our young people and even, middle-aged people and young adults really need to know about. We need to be well-versed in the needs of the older adults as well as normal changes of aging.
True. So true. There's the whole concept of the longevity economy as we have more and more people
Yeah.
older adults, that everybody, that's all hands on deck. And I think that's a nice dovetail to the next breakout group, engaging intergenerational learners through age-friendly universities. So anyone from that group that would like to share. And I think it was Rajan who was coordinating that one. Maybe you can share a few highlights. And we can open it up to the next one, enhancing professional skills for interprofessional geriatric care setting. So we'll combine those two, and anybody who wants to make a comment or suggestion or thought. And I think that one was Hosea Kramer. Josea.
Hi, yeah, this is Josie Kramer. And I appreciated, Jenny Kim, thank you for moderating that session. I think one of the things that came out of it was how unique the VA model is in so many different ways, that the VA has nationwide integrated whole health into its way of doing business. And that is part of it. That actually came out as a question, and how do we teach that? We don't duplicate anything that already exists, and that exists. So that was kind of heartening to have an opportunity to think about the program. Another interesting thing that came out of the session for me was we have this very robust model that developed over time for continuing professional education, and it's longitudinal. So this is for people already in primary care. We're educating the existing workforce, and it's helped to maintain the workforce, not only personally, they see value out of it, but also have told us that this is one reason that they remain in the VA, that they feel valued and they're able to do this work. But I think one of the questions was, did I ever expect this to happen in this big way? And the answer is no, I really didn't. I confess to you now. But I think that the lesson here is that just because just start it, just do it. Be nimble, be inventive, be ready to be a victim of your own success time and time again. It's terrifying. And we can make these changes. We can change healthcare systems through interprofessional education at the continuing education level. And so I thank you too, all the participants, for giving me insight into the program. I wonder if anyone else had any comments.
I think the only other element that I mentioned is the VA has really done some excellent programs, and to somehow share them broader with the Global Forum and traditional universities and integrative health and medicine programs, because I think that they're, in many ways, I think they are offering some excellent models that could really help us in addressing the needs of the aging population.
Thanks, Liza. David.
Yeah, I just thought that one of the things that came out, it was a great sessions that we had there. I know that when Martin was having conversations in one or two of these things, we talked about geriatric moving into wellness and calling something lifetime health. Some of the non-educational communities like Kaiser have begun these wellness programs in recognition that things are going to be moving. And as we follow the money, and we find that wellness can bring positive economic results for those insurers, we'll see more of this coming. And I think that's very good as I enter middle age and begin to understand that lifetime health is coming my way. The fact that Kaiser and some of these other programs are doing this in the VA, again, I gave a shout out to Dr. Kramer's program, because it is so instructive for what is possible. And when the interprofessional groups do this, I'm here representing the Academy of Integrative Health and Medicine as part of this. And those of you who know me, I've had a long career working with integrative health and chiropractic and other alternate healthcare providers. And so this is, the world is changing, and how do we keep up? Not only is the curriculum problem a problem because everybody says it's so full, with the recent Supreme Court decision completely changing the way healthcare is going to be taught in the future. It's a time where some of these insertions into the curriculum might be able to be accomplished. Thank you for great sessions here the last 2 days.
Thanks, David. That was really well said. I think we'll open the floor up to the final group, the Virtual Interprofessional Consultation Clinic, and take any comments from that group and or any of the other groups as well. I think we have a few minutes for some final thoughts.
So I'll jump in. So
Please do.
Facilitate this wonderful session.
Yes.
As part of the planning committee, we hope that we would find some example of a program that people could maybe go home and really try to start in their own place. In particular, bringing in some of the healthcare professionals who aren't often included. And in this case, we found Kristen Roof from the University of Florida, who talked about not only family medicine and nursing, but also dietetics and mental health professionals. Bring it in virtually. And we don't have time to go over it again, but if it all intrigues you, I encourage you to look at the recording when it's up and or contact Kristen to get a good look at this program that's really quite innovative. And one other thing, one of the participants, I can't recall who it was, wanted to remind all of us that patient is also part of the interprofessional team.
Absolutely. Yes. Patient and family. So true. Any other contributions?
I'll just comment that the system is changing very slowly. CMS is putting some major financial pressures on the system. They just cut the physician payment system by 5% this coming year. I don't know who's going to absorb that, but CMS is trying to move to what's called value-based care and people taking on up and downside risk. And if you think that's not going to change the world, just watch what happens when people are taking downside risk for the cost of care. It's a very slow process, but it's going to re-engineer a lot of things about the way things are done. And I think my hope as a public health person is it's going to move us toward a really aggressive effort to keep people well, as opposed to respond to fee-for-service incentives. It's taken a long time, but the federal budget cannot stand much more of this fee-for-service slope, which is gobbling up the GDP relative to other countries. As we know, worse outcomes, higher cost. We need to fix it in America. So I think we're going to have some positive changes. It's just going to take a while.
We may want to look globally for examples of others doing it well or better to learn from.
A lot of countries have a lot better systems that do things a lot more effectively than what we're doing.
Yeah. Yeah. Okay, well, if that, I think those were good thoughts to conclude on behalf of the co-chair for the National Academy, the Global Forum, Pat DeLeon, and then the co-chairs for this workshop as well. I would like to conclude this workshop, but I'll share one observation or one thought. Some years ago, we held a workshop that was on a design thinking approach to, and the topic at that time was stress and burnout in the health workforce. And we were trying to bring that concept of design thinking into the space of health professions education. And if I just played out, the design thinking approach is to empathize, to define, to ideate, to prototype, and to test. And as I'm reflecting onto this workshop, I think we did exactly that. We took a design thinking approach to this issue of caring for an aging population, because our first thought was we empathized, right? We collectively brought a group of people here who are who are already naturally empathetic, but we heard the voices of our older adults, and we've heard from a number of individuals, the learners themselves, to really empathize with the issue. The concept of design thinking starts with the issue at hand, or your beneficiaries in front and center. And then the second part is to define, which I think we did really well with quantitatively and qualitatively thinking about the workforce, the health system, all the needs that are out there and that we need to meet. And then ideating and prototyping. I think we've heard a great number of fantastic examples which really demonstrate that this challenge for us of meeting the needs of an aging population is not distant, it's upon us. And we already have some fantastic things already in play. And the last part of this model is to test. And then I think we'd have to add disseminate, because I think, to Cheryl's point, we've got great, things out there, prototypes, examples in our health system and the education system. We now need to have a space where we can find those best practices and then probably apply our implementation science lens to really test drive those and scale them up. So I think we did here what we do best, which is design thinking and trying to address this challenge ahead of us of preparing for an aging population. So well done, I think, to the team. Kudos to the chairs, to the workshop committee. I know lots of hours and creative thinking went into pulling this together. Thanks to Patricia and Hannah as well for being the anchors for all of this. And thank you for all of you for a really vibrant and engaging workshop. So thank you.